A very good morning to one and all. And now we are starting this international session. And our next speaker is Professor Seyhan B. Ozkan. Dr. Seyhan does not deserve any introduction. She graduated from University Medical College, Ankara, and undergone ophthalmology training in SB Newman's Hospital, Ankara. Subsequently, training was done in Moorfield Eye Hospital, London. She is Professor of Ophthalmology at University Medical College, Edin, currently in private clinic. She has around 130 published papers, 10 book chapters, and editor of 21st ISA transaction book. She has been local organizing secretary of meeting of European Star Business Association in 2004, local organizer for meeting of International Star Business Association in 2010 in Turkey. She is past president of European Society of European Star Business Association and past president of International Star Business Association. And thank you, Dr. Seyhan, for accepting the invitation. And you have always been part of our conferences. And now over to you.
Thank you, Professor Dadeya, for this very kind introduction. And I've shared my screen. Do you see my slide?
Yes.
Yes.
I think it's okay. All right. Yeah. Thank you. So, dear moderators, dear colleagues, it's my distinct pleasure to participate in this SPOSI meeting, and it's been a great honor for me to be with you in this meeting. So, I'm going to talk about the role of imaging. So, first of all, why do we need imaging? Obviously, the first reason is neuro-ophthalmological problems, and other than that, various paralytic, restrictive, developmental, traumatic, iatrogenic, inflammatory problems of ocular motility require imaging. So I'm not going to talk about neuro-ophthalmological problems during this talk, and I will mainly focus on MRI. So when we get an MRI, we get information about the muscle size, shape, structure, function, paths and pulleys, muscle-globe relation, and accessory muscles and bands. So if you look at these three patients, they all have abduction deficiency, but they all have different problems. The first one is a 6-nerve palsy. In that case, we expect to see the lateral rectus muscle with atrophy. The second one is a blowout fracture. There is nothing wrong with the lateral rectus muscle. And the third one is a Duane syndrome. And again, lateral rectus appears normal. Of course, there are lots of clinical clues for differential diagnosis. However, sometimes these clues may be very subtle and we may need to go on imaging. When we look for information about muscles, for size and volumetric analysis, the thickest coronal images are used, and for evaluation of muscle paths and shapes, axial scans for horizontal recti and sagittal scans for vertical recti are used. For sagittal images, we need to get a perpendicular scan. On coronal images, when both orbits are scanned together, if we look at the muscle size, it may spoil especially the size of lateral rectus muscle. So we need to ask for a quasi-coronal scan, and both orbits needs to be scanned separately. So we need to remind this to the radiologist. Kinematic MRI is a technique that gives us information about the function of the muscle. It requires long examination time, and the high cooperation of the patients, radiologists and ophthalmologists are required. And if you look at this image, there is a paradoxical contraction of inferior rectus muscle on upgaze, and this is a Y pattern deviation. So it's been demonstrated that lack of integrity of soft tissues is responsible for motility problems, as sagging eye syndrome in the elderly and myopic strabismus in the ones who had high myopia. So you can see the degeneration in the lateral rectus, superior rectus band here. And in these patients, there is no globe dislocation, but there is a limitation of abduction with lateral rectus sag. So in highly myopic cases, there is a dislocation of the globe. So the angle of dislocation is a concept that we need to make the radiologist familiar and with that we need to ask. So this patient has a high myopic strabismus with limitation of abduction and elevation. And so the treatment is totally dependent on that, as described by Yokoyama. It is the muscle union surgery to relocate the globe into the muscle cone. This is a very similar case, and she also had high myopia, but when we look at the MRI, we have seen that there was nothing wrong with the globe. So this was a real sixth nerve palsy. So there was denervation atrophy, so she underwent transposition surgery in combination with toxin injection. Nobi syndrome is another subgroup of highly myopic cases. So in those cases, the location of the staphylomata may cause bizarre motility problems. Extraocular muscle compartmentalization is a new concept, and then the MRI demonstrates the selective atrophy in the muscles, so it gives us the indications for compartmental muscle surgery. So in congenital neuropathic strabismus, it's been demonstrated that cranial nerve aplasia or hypoplasia is very common. And as a result of that, we see lots of problems in the extraocular muscles, as it is the case in that patient. She had bilateral synergistic and vertical divergence, and this is her preoperative appearance. So when we obtained MRI, we have seen that she had bilateral medial rectus hypoplasia, right inferior rectus hypoplasia, and in the left eye, there was no superior rectus muscle, and she also had bilateral inferior oblique hypoplasia. So the surgery was directed through those, and recessions were performed, and we have found numerous accessory tissue bands, and they were all excised, and this is the postoperative appearance of her. Well, it's known that Duane syndrome is the most common form of CCDD. So in those cases, many years ago, we have demonstrated that the lateral rectus appeared normal, and in other more detailed studies, it's been demonstrated as well, because this is not a muscle with lack of innervation, but there's a misinnervation. So in straightforward Duane cases, there's no indication to go on MRI. However, in atypical forms of Duane syndrome, MRI is very helpful. So this patient has a vertical retraction syndrome in combination with a Y pattern. So when we look at the MRI, we have seen that on upgaze, the inferior rectus muscle remained contracted, and there was also an accessory tissue over the inferior rectus muscle. During surgery, we could not reach this tissue, so inferior rectus muscle was recessed. And as you can see here, both the vertical limitation of motility and the Y pattern disappeared after surgery. This case has an inverse Y, or the so-called lambda pattern deviation. And when we look at the MRI, to our surprise, we have seen that this patient do not have any inferior rectus muscles, despite she can do pretty good depression. But instead, she had this accessory muscle below the optic nerve. And on kinematic MRI, we have seen that this tissue was a real muscle, which was demonstrating a paradoxical contraction on down gaze. So we decided not to do any surgery for this patient. This is again another atypical case with upshoot on abduction. So on axial kinematic MRI, we have seen nothing wrong. When we look at the coronal scans, we have seen that the superior rectus muscle demonstrated a paradoxical contraction on abduction. So superior rectus muscle was recessed. But then we have, depending on the forced action test, we explored the medial rectus muscle and found this accessory tissue. And when MRI retrospectively was evaluated by the radiologist, he identified this tissue after surgery. So this is another case. There's a tissue band towards the limbus. On MRI, we have seen that there's a tissue bridge between the superior oblique and superior rectus muscle, and excision of this tissue did not make any difference after surgery. Congenital Brown syndrome is an area that we have studied before, and we have found that there was tendon trochlea complex enlargement and irregularity. And in this study, we also looked to find any clue to identify the ones who will have spontaneous improvement, but we could not find any clue for that. So in congenital Brown's, we do not routinely ask for MRI. However, acquired Brown syndrome is a problem that we do ask for MRI. So this is a patient who had acquired Brown syndrome related to intratrochlear hemorrhage. There's spontaneous improvement. This patient had a supraoblique myositis, and the problem was resolved after non-steroid anti-inflammatory treatment. This patient has right trochleitis. After steroid treatment, the problem was resolved. And this patient has a supraoblique tendinitis in the left eye. And after injection of steroid into the trochlear area, the problem was resolved. So they all have different problems, and we can identify this with MRI. In vertical strabismus, these 4 patients all have different problems with vertical limitation of ocular motility, and MRI is helpful to identify those. And in a group of patients with monocular elevation deficiency in previous years, we looked for orbital MRI, and we tried to see what was going on, especially on superior rectus muscle. And in our study group, we have been unable to see any denervation atrophy. So in our group, the etiology was not superior rectus palsy. However, in this case, she had previous orbital surgery, and she underwent a suprarectus resection, which was a totally useless surgery. As you can see on MRI, there is severe denervation atrophy. So making a resection in a totally dead muscle is only waste of ciliary vessels and decreasing the chances for transposition surgery. So this patient has a so-called double depressor palsy, and on MRI, we have found that there was no denervation atrophy in neither inferior rectus or superior oblique muscle, and the etiology was not a paralytic problem. And thyroid eye disease is a problem that we need to see that the disease is inactive. So in this patient, you can see that the clinical activity score is negative, but before surgery, I always ask for an MRI. So when we look at the MRI, we have found that there was significant disease activity in the muscle, so we postponed surgery for this patient. Lost muscle is another patient group that MRI is very helpful for us. So with MRI, we can locate the muscle. This is a patient who had pterygium surgery and lost muscle. And when we look at the imaging, we see that the medial rectus muscle was in a posterior manner, but we have been able to relocate the muscle, and this is his appearance postoperatively. So when imaging is required, first of all, unexplained ocular motility problems, high myopia and strabismus following orbital trauma, thyroid eye disease, atypical congenital motility problems, lost muscles, and painful ophthalmoplegias. So the take-home messages is, first of all, the ophthalmologist must be familiar with the interpretation of the findings of the imaging. So reports are not enough. We need to see the images. So good coordination of the radiologist and ophthalmologist is essential. So we cannot obtain the necessary information by routine MRI examination. So the ophthalmologist must address the possible problems to look for, because it is a time-consuming examination and very special scans may be required. So the imaging methods needs to be individualized depending on the clinical problem. And I would like to acknowledge my radiologist colleagues who helped me to solve these complex cases with me. And I'd like to thank you for your attention.
Thank you, Professor Seyhan, for an excellent talk. Anyone would like to ask any questions? Anyone from the...
Sir.
Dr. Mayank.
Thank you, ma'am. It was such an excellent lecture. I would like to ask, ma'am, what special instructions would you give to your radiologist when you are asking for a MRI scan, especially for when you are looking for the extraocular muscles? Because at times we have to deal with different radiologists, and our instruction should be well and clear. So with contrast, without contrast, it should be a quasi-coronal, quasi-sagittal, how much millimeter cuts, and in what axis do you want to see the globe? How do you define those instructions? Or is it like you're working as a team effort and you're yourself going and doing the MRI?
So thank you. For imaging the muscles, there is no uniform instruction to give the radiologist. So it depends on what you suspect to see. Well, if you remember the case with vertical retraction syndrome, let's say. So when I send this patient to the radiologist, I say that I'm expecting to see some problem in the inferior rectus muscle especially. So it needs to be scanned nicely. And if you're asking for, of course, kinematic MRI is something that you need to be very precise. And well, I must say that in our first kinematic MRI examinations, I personally went into the tube and made these 7 points. And then we understood that just with having 3-point scans, we can get the necessary information, which significantly reduces the examination time. So considering the contrast enhancements, it depends on whether you expect to see something like that. But let's say even in a acquired Brown syndrome, we have seen that the patient has a myositis problem. So I do not clearly say that I ask this with or without contrast. So it is the decision of the radiologist what he sees when he gets the image, and if the radiologist considers that contrast is required, and then it's okay. And so it is, as I've mentioned, it is an individual decision, but it is not something that send the patient to the radiologist and show me the muscles. It's not like that. So if we are considering to see a problem in the trochlear area, then they do very nice scans for this, and they can do in different scans in different planes. So it is an individual decision, and we need to write detailed information, and we need to write the possible problems that we expect to see. Then the radiologist can give us what we need to do, what we need for this patient.
Yes, ma'am. Thank you. Ma'am, another one, does 1.5 Tesla or 3 Tesla, does it really make a difference?
Well, actually, of course, 3 Tesla is very sensitive equipment and so on. But all the images that I've demonstrated to you, some of them were very old. In the there was also image even in 0.5 Tesla at the very early study on Duane syndrome and so on. And the other ones were with 1.5. So the quality of the image that you get significantly changes depending on the time that you spend for scanning a patient. So, I mean, you can get a useless image with 3 Tesla, and you can get a perfect image with 1.5 Tesla. So that's why the radiologist is very important. He's the critical person. So I advise to have a good radiologist friend. This is really useful.